First of all, good evening to all the moderators, speakers, and all the worthy attendants of the meeting. Now I'm going to talk on pre-anesthetic evaluation and optimization of a patient with diabetes mellitus. So as we all know, diabetes is a heterogeneous metabolic disorder characterized by elevated blood glucose concentration secondary to either resistance to insulin, insufficient secretion, or both. It is characterized by multitude of metabolic disorders, diffuse microvascular lesions, and long-term organ complications. Now, the diagnostic criteria is according to the American Diabetic Association given in 2015, where then the glycosylated hemoglobin, if it is more than 6.5%, fasting blood glucose level is more than 126 milligram per deciliter, or the glycemia after 2 hours of oral GTT is 200 milligram per deciliter, where no consumption of calorie intake is at least where after 2 hours of oral GTT standard GTT consumption, the blood glucose level comes to more than 200 milligram per deciliter. Patient with classical symptoms of hyperglycemia or hyperglycemic crisis with random blood sugar of more than 200 milligram per deciliter. During the investigation, another class of patients have been described. They are called pre-diabetics who have fasting blood glucose level between 100 to 125. Glycemia after oral GTT as 140 to 199 milligram per deciliter, and HbA1c between 5.7 to 6.4%. Coming down to the classification, where type 1, there is an autoimmune destruction of the beta cells. Such patients are insulin dependent and are much more prone to ketoacidosis. Type 2, which is the most common type, ranges from predominantly insulin resistance peripherally with relative insulin secretion deficiency to predominantly insulin secretory defect with insulin resistant peripherally. They are managed by oral antidiabetic drugs. They are susceptible to hyperglycemic, hyperosmolar, non-ketotic state. Then comes the gestational diabetes. This forms an increased risk of developing type 2 diabetes within 15 years in 3% of the pregnancies that develop such states. Other specific types are genetic, drug-induced, chemical-induced, induced by infections, etc. Now, why is the importance of managing diabetes in surgical settings so crucial? Because metabolic perturbations that take place lead to hyperglycemia, which can result in post-operative sepsis, endothelial dysfunction, cerebral ischemia, impaired wound healing. Stress responses can lead to diabetic ketoacidosis, hyperglycemic hyperosmolar syndrome, longer hospital stay, unmanaged hypoglycemia. They can cause a lot of neurological complications like somnolence, unconsciousness, seizure, irreversible neurological insult, and death. They have a higher incidence of mortality and morbidity during the perioperative period. Now, what are the goals we aspire to get once we are assessing a patient of diabetes for preoperatively? Reduction in overall patient morbidity and mortality, avoidance of severe hyperglycemia or hypoglycemia, maintenance of physiological electrolyte and fluid balance, prevention of ketoacidosis, establishment of certain glycemic goal, which is 180 milligram per deciliter in critical patient and less than 140 in patients who are stable. So outline of our will depend upon, will outline, if I go on to the outline of our pre-operative assessment, it is identifying the type of diabetes, its management, ensuring diabetes is well controlled. We review the medication, identify the complication, and identify the patients who require critical care post-operatively. Now, coming down to the history part, first we should know the type of diabetes and the management the patient is under, the duration of disease, the current glycemic control, whether a patient has susceptibility to hypoglycemia or hypoglycemic unawareness, related complications of nephropathy, neuropathy, retinopathy, oral patient is on antidiabetic drugs or insulin therapy. If therapy is any therapy, what is its dose? What are the dose timings? This all has to be taken into consideration. And other risk factors for atherosclerosis have also to be identified. Recent infections, because these patients are more prone to post-operative. infections in the post-operative period. Similarly, it is very important to identify patients who come with undiagnosed diabetes mellitus or impaired glucose tolerance that present for surgery. There can be as high as 24% of such patients. They need careful evaluation because these are the ones who are very much prone to stress hyperglycemia, which causes the similar symptoms of endothelial dysfunction and infection and sepsis in the post-operative period. Identification and documentation of the peripheral neuropathy is also very important, and the type of surgery the patient has to undergo also to be taken into consideration. Now, coming down to the physical examination, apart from all the regular examination, blood pressure assessment becomes a very important part of preoperative examination, fundus examination to rule out diabetic retinopathy. And moreover, changes in the retinal circulation may hint at similar changes in the brain. Homology, there is homology between the retinal and cerebral circulation. Difficult airway can be identified if the patient has a stiff joint syndrome, where we can find the prayer sign or the Palmer print sign. Thyroid examination also needs to be evaluated because 15% of type 1 diabetes are associated with autoimmune diseases like Hashimoto's thyroiditis and Graves' disease. Now, specific assessment and management include evaluation of the glycemic control, cardiovascular complication, diabetic nephropathy, gastroparesis, other autonomic neuropathies, skeletal system, and the airway. Now, while evaluating the glycemic control, we consider four subheadings. That is evaluation of HbA1c, that is glycosylated hemoglobin, recent blood and capillary glycemic level, identification of hypoglycemia, and identification of episodes of hyperglycemia and ketosis. So two criteria are used basically, HbA1c and blood glucose levels. HbA1c, mean control of over previous 3 months. It depicts the glycosylated hemoglobin depicts the mean control over previous 3 months and carries a negative prognostic value regarding the post-operative cardiac risk of infection, sepsis, and poor wound healing. 1% rise in HbA1c may reflect as high as 40% increase in the cardiac risk. HbA1c more than 7.8%, there is increased risk of post-operative complication. Postpone surgery if it is more than 9 or less than 5 due to lack of glycemic control and recurrent severe hypoglycemia respectively. While therapeutic adjustments are required for patients who are between 8 to 9, where between 8 to 9, we have to reinforce the therapy. And between 5 to 6% of HbA1c require reduction in their therapy. Now, second is recent blood and capillary glycemic value. There is strong correlation between the glycemic levels at admission and post-operative morbidity and mortality. Various studies have found that more than 2 grams per liter of blood glucose levels will increase post-operative mortality and morbidity, while 1.8 gram is associated with less risk. Now, perioperative glycemic targets is a matter of debate that various societies have given various target levels, but generally what is followed is a broader concept of between 108 to 180 if we are going to strictly follow it, or maybe in emergency state where from 72 to 216 milligram, the broader value. Now, identification of hypoglycemia. Again, the level of hypoglycemia is still a matter of debate. Patients may not show critical signs clinical signs of hypoglycemia. They can be found in patients who are fasting preoperatively, because fasting itself is a catabolic state, and irregular meal intake, administration of hypoglycemic drugs, decreased clearance of antidiabetic drugs following deterioration of renal and hepatic function, patients who are on insulin secretors, and when the disease is a long-term one. Hypoglycemic episodes can also present as unexplained malaise in diabetic patient. When they present, they should be taken as hypoglycemia until other proves otherwise, even if the blood sugar level at the time appears to be normal. Serious hypoglycemia is once when the patient during hypoglycemia requires assistance of other person. Now, recent hyperglycemia is easily identified by glycosylated hemoglobin levels In type 2, they require intensification of hypoglycemic drugs, which is personalized and validated by expert prescribers or diabetologists. Then type 1 and type 2 on insulin, at the time which hyperglycemia occurs, is assessed by auto surveillance booklet, and doses should be modified. Now, this gives a broader view of when to postpone surgery and when it is in the green zone, when we can take up, or where we can ask the practitioner or a diabetologist to alter treatment. Cardiovascular complications, 75% of the diabetics die of atherosclerotic complication. They, along with the inherent cardiac involvement due to diabetes, the coexisting factors also matter, like hypertension, lipid abnormalities, smoking, and familial history of cardiovascular problems, glycemic control, duration of diabetes, presence of nephropathy. Now, silent MIs, 30 to 50% patients have asymptomatic. They are asymptomatic. The silent MI is not diagnosed, and which can only be done by provocation tests like exercise stress testing, myocardial scintigraphy, stress echo, or stress MRI. However, these tests should be reserved for patients who are at higher cardiovascular risk. Otherwise, perioperatively useful tests can be repeated measurement of troponin levels and ECG. But another thing why we shouldn't take these tests and for all patients is that studies have shown that systemic coronary revascularization before non-cardiac surgery is not useful to reduce the rate of post-operative MI. Cardiac failure, again, 2 to 3-fold higher risk in diabetic patient. And it is the preclinical stage can be diagnosed by ECG, and LVH can be diagnosed. Diastolic and systolic dysfunctions are present, and pro-BNP and BNP can be measured in these patients. Then comes to what is the most important cardiac involvement. What we see is the CAN, that is cardiac autonomic neuropathy. Clinical, subclinical phase, the anomalies of heart rate at baseline and abnormal variability during standardized tests, they appear totally normal once we do the general physical examination. Early phase has slight resting tachycardia, while only advanced stage, which is rarely seen, as persistent tachycardia, orthostatic hypotension, postprandial hypotension, hypoglycemia, unawareness. Now, how do we test for CAN? The there is a battery of tests that can be utilized to assess CAN, like beat to beat heart rate variability, where patient lies supine and takes a deep breath at the rate of 6 breaths per minute. And this causes an increase in heart rate, while it is normal. The difference in heart rate is 15 beats per minute when it is normal, and while it is less than 10 beats per minute when it is abnormal, considered abnormal. Heart rate response to standing. Heart rate response is tachycardia. Once the patient stands, within 2 minutes, the heart rate response is tachycardia, followed by reflex bradycardia. Now, this is measured by measuring the RR interval and taking out the ratio of 30th is to 15th beat after standing. And if it is less than 1, it represents an abnormal finding. Heart rate response to Valsalva maneuver, when patient breathes in a manometer at 40 mm Hg for 15 seconds. Then the Valsalva ratio, that is maximum to minimum ratio between the longest and shortest RR, if less than 1.1, denotes CAN. Orthostatic hypotension, that is within standing, 2 minutes of standing, a rise in systolic BP of more than 30, and a diastolic of more than 10 mm Hg, and diastolic of, systolic of more than 30 mm Hg and diastolic of 10 mm Hg represent orthostatic hypotension. While blood pressure response on sustained hand grip, if the diastolic pressure falls to less than 10%, then it is considered as a positive for CAN. Current recommendation to test for CAN is type 2 diabetic patients with more than 5 years of disease, type 2 diabetes patient if microangiopathic complications occur. So detection of can preoperatively appears to useful to identify the patient at risk for perioperative hemodynamic instability and cardiovascular complication. They also have decreased ventilatory responsiveness to hypoxemia and hypercapnia. Now, what is the minimal cardiovascular assessment on anesthesia consultation that should be done for all the patient? It is to identify my slides have stopped working. I'm so sorry. My slides have stopped working.
Okay, it's fine.
Sir, I don't know. The slides are not moving. Yes, now they're moving.
Okay.
Sorry, I'm so sorry to waste the time. So history of hypertension, cardiovascular disease should be sought. If the patient is under the cardiologist, treatment should be reviewed. Any vascular revascularization has been done, that should be reviewed. Symptoms of angina, mild or atypical, should be noted. If there are symptoms of heart failure or peripheral arteriopathy, should be noted. Orthostatic or postprandial hypotension should be documented. Episodes of asymptomatic hypoglycemia should be noted. Current treatment should be documented. The early investigations should be reviewed, like ECG, echo, arterial echo, Doppler. Investigation for SMI that have been done. Meticulous cardiovascular examination should be done. Fresh echo, ECG, wherever required, should be done. If SMI is suspected, it should be investigated if Lee's index score is 2 or functional capacity is less than 4 maths. 10 is suspected, then heart rate variability tests should be done and tests for orthostatism should be done. Cardiologist referrals should be done for specific management. Now, cardiac diabetic nephropathy, now known as diabetic CKD. Earlier, the diagnosis was based on microalbuminuria. Now it is classified on the basis of albuminuria to urinary creatinine. It is classified into 3 stages, and GFR, that is classified into 5 stages. CKD G1A1 and G2A1 is considered stable. Now, what is the impact of diabetic CKD on anesthesia? It is an independent risk factor for development of ARF. We have to avoid nephrotoxic drugs perioperatively, and hemodynamic optimization is required to maintain renal perfusion. This is the basic classification, what they have given. Now, gastroparesis, it is delayed gastric emptying in absence of any mechanical obstruction. Symptoms are anorexia, nausea, vomiting, abdominal pain, sensation of bloating, early satiety, and slowing of digestion. Signs include abdominal distension with classic clepotment, and they can be diagnosed preoperatively by a history suggestive, ultrasonographic measurement of the antral area, and echo, which can show solid residues within the stomach. Now, other autonomic neuropathy, cardiovascular, we've discussed. Gastrointestinal, apart from gastroparesis, esophageal dysfunction, small bowel dysfunction, and anorectal neuropathy can also occur. In the genitourinary system, neurogenic bladder, where incomplete bladder emptying, post-void urinary retention, increased frequency of micturition occurs, and that can lead to post-operative urinary infections. Others can be hypoglycemia unawareness, impaired microvascular flow to skin, flow to the skin leads to dry parchment-like skin, which causes fissures and ulcers, increases chances of infection and gangrene in the postoperative period, and anemia. Now, for airway examination, stiff joint syndrome when present can also tell us that there can be a difficult airway, difficult orotracheal intubation, limited mobility of temporomandibular joint when present, of the atlanto-occipital joint and cervical spine when present can help us to predict difficult intubation. Scleroderma, firm wood-like non-compressible skin of the skin, and nuchal edema also hampers intubation. Now, it is diagnosed by the prayer sign, where the Stiffness of the interphalangeal joint. The patient fails to oppose his interphalangeal joint despite his maximal effort, and which can be graded by taking an impression, inked impression on a paper and seeing the percentage of the hand that has been imprinted. Now, optimizing the treatment preoperatively, oral antidiabetics, and this will be part, the pharmacological part will be discussed by Dr. Jatin Lal. I would come down to optimizing the therapy of oral hypoglycemics in the preoperative period. First of all, biguanides, metformin, there has been long debate, but now it is quite clear that it can be continued on the day of surgery without much chances of an adverse effect, but have to be discontinued in patients with renal failure who have a GFR of less than 60 ml per minute or an elevated creatinine level, or they have some iodine-based dye that has been injected. Sulfonylureas are long-acting. On the day of the surgery, you have to omit the dose regardless of the time, that is, be it a morning surgery or an afternoon surgery. Before I move further, all the oral and antidiabetic and non-insulin injectable antidiabetics can be given as a regular dose on the previous day of the surgery. The changes are to be done just on the day of the surgery. Glinides and alpha glycosidase inhibitors, we have to omit the morning dose when the surgery is in the morning. While when the surgery is in the afternoon, these both classes can be given as a pre-meal dose where a breakfast is being given to a patient. While glitazones, regular use, no contraindication until and unless there is chances of cardiac congestion because they cause water retention. And while for DPP-4 and GLP-1 analogs, their regular use can be made. Omit the dose on the surgery if there is a potential of delay in the gastric emptying. While for SGLT2 inhibitors, there is not sufficient data to suggest whether it can be continued on the day of surgery. Hence, it should be omitted on the day of surgery. Attention should be paid on concomitant use of the diuretics. Now coming down to insulin management. Pardon?
हाँ जी, घंटे के बाद है ना?
Type 1 diabetics, they are on multiple insulin injections. Physiological dosing is given, and a rapid short-acting dose is given prior to meals. In type 2 diabetics, oral hypoglycemics, non-insulin injectable drugs, or insulin are given. It is important to remember basal metabolism uses approximately 50% of the daily insulin produced in individuals, even in the absence of food. So it is mandatory for the patients to receive. Type 1 patients should be given insulin so that the basal requirements are met. Otherwise, ketosis can be precipitated. Now, variable rate intravenous infusions, they are infusions, which are generally given to the patient in the preoperative phase when they are likely to miss more than one meal. So generally, they are taken as separate insulin and glucose infusion, where glucose is given at the rate of 5 to 10 gram unit per hour, and short-acting insulins are given at 1 to 2 unit per hour. Rate of infusion is calculating the blood glucose level and dividing it by 100. Hypoglycemia, we have to decrease the infusion, but never stop it because and keep it minimal at 0.5 unit per hour to meet the basal requirements. Now, regarding the preoperative modification of the insulin, continuous subcutaneous insulin, like on the previous day, on the day of surgery, be it a morning surgery or afternoon surgery, you don't have to remove the basal infusion. Reduction to 20 to 30% are required if the patient is missing dinner or a bowel prep is being done. So patient does not take the top-up doses which are taken before the meals. The basal infusion remains the same. Long-acting or the basal insulin like Glargine, they have, like on the previous day, the dose has to be maintained, but again, night dose, 20 to 30% reduction, again in patients who are hypoglycemic or requiring a bowel preparation. Glargine is generally given as an HS dose, but if the patient is taking in the morning, it can be given as a morning dose because it does not cause peaking. It provides a basal supply of insulin to the body, so it is continued on the day of surgery as well. When intermediate insulin are given, the doses have to be maintained a day prior, and again 20 to 30% reduction, as we've already discussed. On the day of surgery, whether morning or afternoon, reduce the morning dose to 15% and check blood glucose level at admission. Even keep evening dose unchanged if the surgery, after surgery. If there is a pre-mixed, dose is maintained, and on the day of surgery, 50% reduction of the long-acting is done while the fast-acting is not given. For the fast-acting or the short-acting, on the previous day, maintain the dose. On any circumstances, the dose has to be held on the day of the surgery. General guidelines: the patient should be put on priority in the surgical list. The gastroprokinetic agent or an H2 blocker should be administered. Insulin and antidiabetic treatment should be adjusted depending upon the type of treatment, type of surgery, type of list. Now, while coming down to a special case of ambulatory surgery, insulin management depends upon the number of meals missed by the patient. That is, if none are missed, nothing is changed. If one is missed and the time is noted, if the surgery is very early in the morning, we give the dose to the patient, the morning insulin dose to the patient, and a late breakfast. While if more than 2 are missed, we can follow the guidelines of a major surgery. And so timing of the procedure is also matters. If there is a late surgery, patient may be taken into insulin infusion, IG infusion, on the day of the surgery from 7 a.m., both in ambulatory surgery and as well as in the major surgeries. The fasting blood sugar and serum electrolytes are ordered on the day of surgery. Blood glucose levels should be checked at 1 to 2 hours intervals. Now, patients who are well controlled on diet, blood glucose levels are well below 180. They do not require anything extra, and IG infusion, if it remains above, if it goes above 180, then an IG infusion is commenced. Monitoring of the blood glucose should be done for 4 to 6 hourly until they resume their usual meals. Patient on oral hypoglycemic agents follow the recommendation depending upon the type of medication used. Commence IG infusion, insulin glucose infusion if blood glucose level more than 180, if surgery is prolonged and complicated. Subcutaneous insulin may be required by these patients in the postoperative period. Now, if the patient is on insulin, maintain the usual insulin doses and diet the day before and fast from overnight. Omit usual morning insulin as per recommendation that have been already discussed. IG infusion should also be commenced in these patients. The blood glucose level must be measured hourly and continue IG infusion at least 24 hours postoperatively and until patient is capable of resuming adequate oral intake. Thank you so much. Now, the peroperative part, Dr. Shashi.
Yeah, thank you, Dr. Kirti. You have deliberated almost all of the topic, taking into consideration all the preparation, preoperative workup, and the drugs. So I request Dr. Baljit Singh to introduce the next speaker, sir. Dr. Baljit Singh.
Yeah. Dr. Singhal, I think Dr. Shashi has been introduced already. Well, she's she's a senior professor in your department and a very pleasant person to talk to. Apart from that, no doubt she's a wonderful clinician and an excellent speaker also. And I think we would prefer to listen to her talk rather than saying good things about her. There are so many of them. She's a very competent anesthesiologist, I must say, and she has a number of publications as well. Over to you, Dr. Shashi, please.
Thank you so much, chairpersons, and a very good evening to all of you. just start sharing the screen. So thank you, ICA, for giving me this opportunity. I shall be speaking on anesthetic challenges in a patient who has diabetes and is scheduled to undergo surgery. So I have some disclosure to announce that I have taken second part of my presentation from this article, and I recommend that especially postgraduates, they should go through this article. It's an excellent article. A diabetic patient can be scheduled for elective surgery, where the surgery is undertaken by the convenience of patient and hospital staff. Then is accelerated, where the surgeons and they have many days for the surgical procedure to be performed. Urgent, where hours can be taken, few hours, not many hours. And immediate can be where you have only minutes to decide whether surgery is to be done or not. And this may be life or limb saving. So what's the impact of surgery on glycemic control? The effects, because of starvation, it can lead on to a catabolic state, and that can stimulate counter-regulatory hormones. Also, major surgery is associated with release of inflammatory cytokinins. Hypoglycemia on the top exacerbates the catabolic effects of surgery. And moreover, there is increase in insulin resistance and decrease in perioperative glucose utilization. So ultimately, hyperglycemia and ketosis can ensue. Perioperative glucose levels, they can also be influenced to a major extent by anatomical location and invasiveness of the procedure. For example, if surgery is being done in thoracic or abdominal areas, the hyperglycemia is more pronounced. Laparoscopic procedures, they are associated with decrease in incidence of hyperglycemia as compared to open procedures. Moreover, it is also influenced to a larger extent by intraoperative fluids and nutritional supports. Especially, I would like to mention here ERAS, because it is being done in many institutes. So for the postgraduates, it is enhanced recovery after surgery. So if carbohydrate preloading is done, then it can reduce catabolism to a great extent. And we all know type of anesthesia. General anesthesia is associated with lesser stimulation of the hormones as compared to regional anesthesia. Just I would like to comment that if patients are preoperatively on IV insulin, I would like to monitor perioperatively 1 hourly blood sugar levels. And if patients are on subcutaneous levels, then 2 hourly. Another important question is when to cancel elective surgery. It's quite a debatable thing. Daily we encounter that, okay, we will not take up this surgery. There is no evidence-based guidelines for that. However, if a patient is having diabetic ketoacidosis or HHS, then surgery should be postponed if it is elective. And generally in literature, it is mentioned that if blood sugar levels are in excess of 500 mg% on the day of surgery, it should be cancelled. So Dr. Kirti has prepared well for me a patient for elective surgery. I have the consent of patient. The patient is nil per oral. Angiolysis has been prescribed along with prokinetics. I have the morning blood sugar and electrolytes. I have arranged glucometer and strips for insulin management in operating room. So careful transport of the patient has been carried out because of they may have neuropathies, and ideally patient should be scheduled as first case. In the OR, I would like to have 2 IV cannulas, 1 for fluids and 1 dedicated for insulin management if required. The goals of perioperative glycemic control will be, if my patient is stable, so it should be less than 140 mg%. I have given here values both in milligram% and millimoles. Roughly the conversion factor is 18. And if it is a critically ill patient, then I would like to have the blood sugar well below 180 mg/%. Avoid any hyper or hypoglycemia to a large extent. The physiological electrolyte and fluid balance should be maintained and prevent diabetic ketoacidosis. It is seen that if all these goals are met, then there is sufficient, significant decrease in overall morbidity and mortality. I will be talking upon the effect of anesthetic drugs. So first I will take about general anesthesia. Benzodiazepines, which are usually given for pre-medication, they have minimal effect in usual doses on glycemic control. However, if they are used in large dosages, they can decrease ACTH secretion and cortisol production, and they decrease sympathetic stimulation. Opioids are associated with hemodynamic, hormonal, and metabolic stability. Moreover, they effectively block sympathetic nervous system and hypothalamic pituitary axis. The point to note is that they provide better control of hemodynamics in patients who are having autonomic neuropathy. Ketamine has a dual effect. Low dosages cause hyperglycemia, and high dosages, they result into hypoglycemia. Most of the IV anesthetics, they have negligible effect on intraoperative or perioperative glucose levels. The point to mention is that propofol use is associated with decreased ability to clear lipids from circulation. Thiopentone doesn't have much effect. Etomidate, although it causes less hypotension and is useful in cardiac patients, but it suppresses adrenocortical function. So subsequently, it may decrease hyperglycemic response. Now about inhalation agents. Halothane, although it is not being used, but as postgraduate, one must know, halothane and isoflurane, they normally do not cause any significant effect on the glycemic levels, but they can cause hyperglycemia in dose-dependent manner. There was an interesting paper who evaluated, the authors evaluated the effect of sevoflurane and desflurane anesthesia on blood glucose levels, and it was found that they do not result into significant increase in blood sugar levels. I found an interesting article about sevoflurane. So sevoflurane preconditioning ameliorates diabetic myocardial ischemia, reperfusion injury. So sevoflurane in diabetic patients results into the upregulation of ERK, and so it results in myocardial protection. Neuromuscular blocking agents, they do not have much glycemic response. However, one should avoid succinylcholine for obvious reasons. Rocuronium can be used if rapid sequence induction is required. And the choice of muscle relaxant also depends on the renal functions. If renal functions are deranged, atracurium can be used. And for airway management, use laryngeal mask airway wherever possible. However, if one is using endotracheal intubation, prevent pressure response to laryngoscopy and intubation. Now, regional anesthesia. Regional anesthesia, epidural and spinal anesthesia are very important because they block sympathetic efferent signals. There is nominal effect on glucose metabolism. They result into inhibition of catecholamine release. And the important point to note is that this occurs irrespective of spinal segmental level. There is no increase in NORAD and cortisol concentration. If the patients are awake, of course, hypoglycemia is better appreciated. Also, there are less chances of aspiration, postoperative nausea, vomiting, and thromboembolism. Patients can resume their oral intake early along with insulin and hypoglycemic agents. A word of caution: if patients are having autonomic neuropathy, it can result into severe hypotension and there can be risk of epidural abscess because of hyperglycemia. Moreover, there are medical legal problems. About medical legal issues, I would like to emphasize to the postgraduates that if a patient is having pre-existing neurological problem or some numbness or neuropathy, and if regional anesthesia, spinal anesthesia, or some blocks, they are deemed mandatory or necessary, one should assess risk-benefit ratio and please document in the file that patient is having this preoperatively and discuss with patient and surgeon. Again, a controversial issue is what IV fluid should be used perioperatively in a diabetic patient undergoing surgery. The characteristics of ideal IV fluid is that it should provide sufficient glucose to minimize catabolism and permit insulin infusion. It should contain potassium. It should be isotonic. It should not cause hypochloremic acidosis. And very important that it should be widely available. So ideal fluid is 5% dextrose with 0.45 normal saline and 20 millimole potassium, 20 millimole per liter potassium chloride. Ringer lactate should be avoided. Normal saline can be used and we are using, but a word of caution that larger volume, they should not be used as they can result into hyperchloremic metabolic acidosis. Now I have induced my patient and what should be my intraoperative glycemic control? The target should be 150 to 200 milligram % intraoperatively glycemic control. It has been seen that if blood sugar levels are maintained between 140 and 170 milligram %, there are lowest risk of adverse outcomes. Of course, it depends on length of operative procedure. If the surgery is short or minor, then maintain pre-operative glucose intraoperatively also. And if it is major or complex surgery, then variable rate IV insulin infusions, they should be used. Just to mention that regular IV insulin is active for 1 hour and serum half-life is 7 minutes. The advantage is that it allows tight glucose control. How to make it? 100 units can be mixed in 100 ml saline, so that will make 1 unit per ml. In type 1 diabetics, the rate of infusion is 0.5 to 1 unit per hour. In type 2, 2 to 3 units per hour, slightly higher. Then I would also like to comment on GIK regime, which is popularly used. It has been documented as inotropic and metabolic therapy in diabetic patients. How does it act? The mechanism of action is that it acts by lowering circulating levels subsequent myocardial uptake of free fatty acids. It increases myocardial energy production by exogenous glucose and it stabilizes intracellular potassium, which may be depleted during the periods of myocardial ischemia. So what's the disadvantage? No individual manipulation of glucose or insulin levels is possible. So it is better suited for blood glucose maintenance after achievement of specific glycemic control. So now from the postgraduates, often in the exams, it is asked that which regimes do you know of? So I will just briefly touch the various regimes which have been described in literature. One is sliding scale for subcutaneous and IV insulin. Other is Alberti regime. Then modified Alberti regime. Then Hirsch regime. Tight control regime. I would like to comment on tight control regime. It is indicated if the patient is pregnant, cardiac surgery, neurosurgery, and critically ill patients who require mechanical ventilation. The advantage of tight control is that it improves wound healing, decreases infection, and neurological outcome is better. Disadvantages: there are more chances of hypoglycemia and it requires frequent monitoring. So aim is to maintain blood sugar around in between 80 to 120 milligram %. Then non-tight regime. Then is Vello regime. So there are these various regimes. So I would like to comment that if someone asks in the exam, so what to use, you can ultimately whatever is your institutional protocol, you should monitor and maintain the perioperative glucose accordingly. Then I would like undiagnosed diabetes mellitus. There have been various articles in the literature which describe that the rate of undiagnosed diabetes mellitus is as high as 10%. And the patients who are having undiagnosed diabetes, they are diagnosed at the time of surgery, or maybe during the emergency surgery, just you had diagnosed that patient with diabetes. These patients are more likely to require resuscitation. The incidence of your chances of reintubation are high, and they require longer post-operative ventilation, and the mortality perioperatively is quite high in these patients as compared to those who do not have diabetes or diabetic. So this much about the elective surgery. Now I'll just talk about emergency surgery in diabetics. Seen that 10% of the patients requiring having diabetes, they present for emergency surgery, and perioperative mortality rate is 50% higher, and this is because of multifactorial modifiable reasons. What are the reasons? Often these patients have multiple comorbidities and are classified as ASA 3 emergency. Microvascular complications they have, and perioperative hyperglycemia can compound risk of AKI, ACS, CVA, wound infection, and systemic infections. Another very important reason is that often in emergency, the glycemic control is not appropriate. It has been seen that 20 surgeries suffer hypoglycemia at any time. So the target should be to maintain per liter. Then 0.6% of the patients with diabetes ketoacidosis, which is secondary to surgical pathology, and very important that it may mimic acute abdomen, leading on. Then insulin may be prescribed inappropriately, and monitoring of insulin if variety of insulins as well. And these patients, they are often on complex polypharmacy. These patients have often complex fluid and electrolyte requirements. They may have pre-existing renal or cardiac disease and kidney injury, use of glucose, natremia and hypokalemia. Then they have pressure ulcers. And very important thing is that they may have unknown time of surgery, like the surgery resident comes and we are bringing the patient, and for hours the patient doesn't turn up. There are unnecessary delays, postponements. So the patients can have prolonged and unpredictable starvation, and then surgical length also becomes, duration also becomes quite unpredictable. So what should be the initial assessment for these patients? Initially assess for the need, whether they or appropriate fluids, and also see whether how much surgery is urgent, assess the comorbidities, assess the current glycemic controls and need for insulin, and ensure that the treatment of hypo and hyperglycemia has been prescribed accurately. Then initial control can be achieved by variable rate IV insulin. However, if the patient is in diabetic ketoacidosis or has had diabetic ketoacidosis, then fixed rate insulin is desirable. The antibiotic drugs right in the operating room. Then assess the risk of perioperative AKI, hold non-steroidals and inhibitors. Do risk assessment for post-operative management, and one must ensure that a senior anesthetist and a senior surgeon are available for the unstable patients, including a diabetologist. And very important, discuss about the patient condition with patient and attend. So what are the risk factors? 65 or more are more prone for AKI than sepsis, hypovolemia, intraperitoneal surgery, heart failure, liver disease, and use of non-steroidal anti-inflammatory drugs. They can all precipitate AKI. So investigations sake of postgraduates, I wanted to just tell them that blood ketone levels normal levels are 0.5 to 3 milligram per deciliter, and urine ketone levels are normally 3 to 15 milligram. And this is a typical, dextro or multi that stick. So which can indicate that whether the ketones are negative, trace, small, moderate, large, or +1, +2, +3. So the levels can be accordingly 5, 15, 40, 80, and 160. 3 to 15 milligrams, then not to worry. Know how to differentiate between diabetic ketoacidosis and hyperosmolar hyperglycemia. The plasma glucose levels in HHS are quite high, and arterial pH is more than 7.3. The anion gap is variable, and bicarbs are more than 18. How to manage? If the patient is having these conditions, insulin should be given in physiological doses. The point to be noted is that the insulin requirement is lower in HHS because the reason is severe dehydration. And rate of insulin infusion should be adjusted to maintain blood glucose between 200 milligram percent in DKA and 250 to 300 in HHS till hyperosmolar state is corrected. Use bedside tests, and point of care testing is now advocated everywhere for glucose management. And involve diabetologist early. Use fixed rate IV insulin with hourly measurement of capillary blood glucose, and prompt treatment of hypoglycemia. Fluid 0.9% sodium chloride with premixed KCl, and very important, reason for decay should be treated. Now the various monitoring, sometimes the patient may require, apart from usual, the invasive monitoring like CVP and arterial blood pressure monitoring. And of course, blood glucose electrolytes. Goal-directed fluid therapy should be used. Maintain hemodynamic stability and encourage early eating and drinking so that patient can resume usual medications early. And multimodal opioid sparing analgesia should be used. Try to prevent PUNV, and regional anesthesia is beneficial in emergency surgery as well if it is possible. And prevent dysglycemia. Post-op considerations, appropriate level of care should be undertaken for the patients. So whether emergency patients can go into HDU or ICU, and elective surgery patients where they can go they should remain in PACU for some time, or they can go to the ward. And the target glycemic range post-operatively should be 140 to 180 milligram percent. Variable rate IV insulin should be reduced after drugs. Ensure basal insulin level is met, and supplemental insulin can be used. So just these considerations about the management. After recovery, it can be discharged home. If the patients are non-critically ill, they can be shifted from PACU to surgical or medical ward with subcutaneous insulin. If patients are unable to take orally, then basal plus correctional insulin is preferred. I'll talk what is correctional insulin. Patient who is having regular oral intake. So what should be done? Basal insulin that should be used. So basal insulin nutritional insulin. So I would just like to comment on correctional insulin. What is that? The correctional insulin is used to counteract hyper the patient's current glycemic level, glucose level, and the desired. You subtract those and divide by 50. So that will give the units of insulin that is known as correctional insulin that is given over and above the infusions which are going on. Then in critically ill patients in ICU, you should have continuous insulin infusion with regular insulin. Blood gas monitoring should be, blood glucose monitoring should be undertaken every 1 to 2 hourly. And these patients have unpredictable glycemic fluctuations. So sole use of fractional insulin is not recommended. Avoid pre-mix insulin regimes as there is risk of hyperglycemia. So glucose trends are more important rather than, 1 or 2 blood glucose levels. So if patients are unable to take oral, TPN is initiated, but try to resume enteral route as soon as possible. So apart from this, good medical and nursing care should be done. There is risk of myocardial ischemia or infarction, specifically 72 hours till 72 hours following surgery. The risk of AKI, pressure ulcers, hyperglycemia, and wound infections, DKA, and drug-related harms can occur. So just a last slide to tell about diabetes and pregnancy. I specifically chose this slide because we are day in and day out, we are managing pregnant patients for cesarean section or otherwise. So pregnancy, we all know, is a diabetogenic state with altered maternal physiology. Therefore, they are more prone to hypo or hyperglycemia. Insulin resistance increases with the advancement of pregnancy, and diabetic ketoacidosis can occur in second or third trimester. Hypoglycemia can lead on to risk of neonatal jaundice, brain damage, fetal acidosis. So tight control is needed. And this is the, for gestational diabetes mellitus for non-diabetic patients. And this is the management for pre-existing type 1 and type 2 diabetic parturients. So to conclude, surgery in diabetics is associated with increased mortality, morbidity. The point to note, the perioperative dysglycemia in adult surgical population is quite ubiquitous and unfortunately often undiagnosed. Appropriate glycemic control should be targeted with careful monitoring of glucose, electrolyte, and blood gas. There are numerous perioperative control regimes which have been described in literature. However, you should tailor it to according to your institutional protocols and use clinical judgment, which is most important. Prevent postoperative complications. A mindful preoperative glycemic control can achieve and try to achieve the preoperative control of glucose, what was the that as soon as possible. And careful management can reduce surgical hyperglycemic complications. Thank you very much.
Thank you so much, Dr. Shashi, for a very comprehensive coverage of the whole topic. It's a large topic, of course, there's no denying that. And there are a lot of challenges that we face on a daily basis, whether it is a diabetic patient who's coming for elective surgery or he's coming for an emergency surgery. Plenty of problems because there can be a lot of other associated comorbidities also. So all these challenges you have covered very well. I'm happy that you covered an area which is very important for the postgraduate student, particularly the diabetes and hypertension, along with many other things, because that's very important from the point of view of the postgraduate examinations. So I think you can sit back and relax for a while. So meanwhile, we'll go to the other next talk. And after that, then we'll have question and answers in case if there are any in the chat box. So I would pass it on to Dr. Singhal for introducing the next speaker, and then he can take it on. Over to you, sir.
Yes, sure. So we have now Professor Jatin Lal, who is also in our institute an anesthesiologist. He has very keen interest in difficult airway management, obstetric anesthesia, and critical care management. And he is also asset to our department. He is our software and computer uh, maintenance faculty also. Wherever we are stuck, we take his help. So he would be speaking on rather important topic, because lot of drugs which are available for diabetes over the last decade have come up. And some are good, some are bad, and literally the things are getting redefined. So he will be talking about recent advances in perioperative management of antidiabetic drugs. So Dr. Jatin, please carry your talk.
Thank you, sir, for the generous introduction. I, I will now share my slides.
Please do.
Thank you, sir. First of all, I want to thank ICA for allowing me the opportunity to speak on such a pertinent topic, the recent advances in the perioperative management of the anti-diabetic drugs. In India, diabetes is becoming a potential epidemic with around about 425 million of patients worldwide in 2017 and projected to get to 425 million by the 2045. The situation in India is also grim. By 2015, there was 69.2 million patients, and it is projected to increase to 98 million by the year 2030. And to top it all, the incidence of diabetes is like a tip of the iceberg. Up to half of the patient with diabetes are undiagnosed. So the perioperative period is an ideal opportunity to identify the patients with hyperglycemia with or without the diagnosis of diabetes, to optimize the treatment of diabetes perioperatively, and to modify their post-surgical course. PCOS study has shown that there is a lot of confusion in the perioperative management of the diabetes. Because it has cited a number of reasons for the same, because there are plethora of the anti-diabetic drugs with different mechanisms for the hypoglycemic control. There are multiplicity of the guidelines and different recommendations. As Madam Shashi have already told, there are numerous regimes. So one is already confused. Earlier, the conventional practice was to withhold all oral hyperglycemic medications on the day of surgery. But the recent literature has shown a tendency has shifted towards the treatment continuation. This shows the various mechanisms how a hyperglycemia has occurred in a diabetic patient. And the most of our
Dr. Jatin? Hello?
Dr. Jatin, you are not audible.
Yeah.
I think some system.
I think he stopped speaking as well, I believe.
Some system glitch is there.
No, he won't have stopped speaking. Probably the system, some audio visual issues.
Oh, थोड़ा आधे घंटे.
Singhal,
yeah.
Can you give him a call?
Yeah, that's what. Yeah, sure.
Hello.
Yeah, that's right.
Yeah.
Welcome back.
I will share my screen again, sir.
Please do.
So I was talking about the various modes, how the anti-diabetic drugs occur. Yes, now they are moving. So we come to the insulins. Then the first is the insulin preparations. So what about the conventional insulins? Earlier, क्या कहते हैं, with the conventional insulins, insulin preparations were of three types: the short acting, the intermediate acting, and the long acting. In the short acting, we had the regular insulins and the semi-lente. The intermediate acting, the lente and isofenes, and the long acting is the ultra-fane insulin. So what was the problem with the conventional insulin preparations? Normally, the body insulin concentration peaks at 30 to 45 minutes after a meal and returns to the basal level after 2 to 3 hours. These regular insulins form hexamers, which dissociate slowly into monomers and thus delaying the absorption. So there is delayed onset of action half to 1 hour, which leads to the postprandial hyperglycemia. And also there is prolonged time to the peak action 2 to 3 hours, and duration of action is 5 to 8 hours, and this will lead to the late postprandial hypoglycemia. Hence the regular insulins cause a mismatch between the need and the availability of the bolus insulin and do not ideally mimic the physiological bolus secretion of the insulin. Regular insulins usually have to be administered 30 to 45 minutes before the meal. So another problem with the intermediate or the long-acting insulin preparations that they are unable to provide a continuous basal insulin control for the 24 hours. So leading to a pre-meal or fasting hyperglycemia, or there may be night hypoglycemia. So what are the newer insulins or the insulin analogs? These are the molecules produced by recombinant DNA technology, wherein the amino acid sequence in the human insulin is changed to alter its pharmacokinetics. However, they bind to the insulin receptors in the same way as human insulin and produce similar effects, so giving rise to a physiological insulin therapy. They are also termed as designer insulins, insulin receptor ligands, or democratic insulins. So what are the merits of these insulins? They have less propensity to form hexamers, and if formed, they will dissociate rapidly into monomers and are rapidly absorbed. So it has a rapid onset of action, 10 to 20 minutes, giving rise to a better control of the postprandial glucose. The peak action is 1 to 2 hours and the duration of action is 4 to hours. So decreased risk of late postprandial hypoglycemia. So the other merits are better mimicking of the physiological insulin secretion, better control of postprandial blood glucose levels, better control of glucose levels in the fasting or interdigestive period, lesser risk of hypoglycemia, action profile independent of dose, site of injection or exercise, so more predictable action, and greater flexibility with the short-acting analogs as they can be given at meals. So we have the two types of, basically three types of the newer insulins. Ultra short acting or rapid acting, this is the insulin Lispro, insulin Aspart, and insulin Glulicin, which have a small onset of action and peak, and duration of action is also small. Then these are mostly used for taking care of the postprandial spikes. And then we have the long acting insulins, the insulin Galargin, insulin Datimer, and insulin D-Glutec, which are used for providing a basal control of the insulin, as their duration of action is very long, 18 to 20 hours. So single dosing is mostly required. For Datimer, it may be twice dosing. Then we have the pre-mixed dosing, NPL or NPA, which is the protamine isofenes with insulin Lispro or with aspartate, and they have a dual action. They will take care of the postprandial spikes and also give a basal insulin control. So what do we do in the preoperative management of insulins? We have a study, the randomized study of the basal bolus infusion therapy in patient management of patients with type 2 diabetes undergoing general surgery published in Diabetes Care in 2011, and they concluded that basal bolus treatment with glargine once daily plus glulicine before meals improved the glycemic control and reduced hospital complications compared with the sliding scale regular insulin in general surgery patients. The study indicates that basal bolus insulin regime is preferred over sliding scale insulin in the hospital management of general surgery patients with type 2 diabetes mellitus. So another thing with the, hello, am I audible, sir? Hello?
Yes, Dr. Jatin, you are audible.
Yes, you are. Please go on.
Yes. Another thing with the insulin preparation was that if we use the basal bolus insulin, the cost may go high. But we have a study in 2017 published in Pharmacology Open that a comparison of the inpatient cost per day in general surgery patients with type 2 diabetes treated with basal bolus versus sliding scale insulin regimes. And they concluded that in general surgery, patients with type 2 diabetes, a basal bolus regime significantly reduced average total hospital cost per day compared with the sliding scale insulin regime. Basal bolus has been shown to improve the outcomes in randomized control trials, and those results combined with the findings regarding savings suggest that hospitals should consider adopting the basal bolus regimes in patients with type 2 diabetes mellitus undergoing surgery. So this shows the various insulin analogs along with their use and recommendations for the surgery. The rapid acting insulins, the insulin lispro, aspartate, and glulicine, these are used basically for the controlling the perindial spikes, and these drugs should be withheld on the day of the surgery. Then we have the short-acting regular insulin. This is also mostly used for the controlling the postprandial spikes, and this should be stopped on the day of the surgery and continued thereafter. Then we have the intermediate-acting drugs like NPH. And for this, the evening dose may be given prior to surgery, but evening meal is skipped. Then you can decrease the dose to 25%. And then the half of the dose should be given on the morning of the surgery. Then we have the mixed preparations, the NPL and NPA. These are used both for the perindial and the basal control, and these should be withheld on the day of the surgery. Then we have the long-acting insulins, insulin glargine, datimer, and D-glutide, basically used for the basal control, and these should be continued on the day of the surgery. Then we have a newer insulin things, the continuous subcutaneous insulin infusions, newer delivery devices. This study shows that there was a review in 2008 in Current Opinions that new insulin analogs and insulin delivery devices for the perioperative management of the diabetic patients. So basically, these are portable infusion devices with subcutaneous cannula, usually deliver an ultra rapid acting insulins like Lispro or aspartate or glulicine, and these are programmed to deliver at low basal rates, 1 unit per hour, and pre-meal bolus 10 times of the basal rate. Use of a pump intraoperatively is practitioner and institutional specific and is an off-label use. It is well tolerated when maintained at a basal rate and when secured from the surgery field. Recommendations are to limit the use of this pump to cases less than 2 hours. Then we have the continuous glucose monitoring, which is the monitoring of the interstitial glucose, and automated insulin delivery devices are commonly used. Results suggest improvement in the glycemic control, less hypoglycemic events, less hypoglycemia, reduced HbA1c, and reduced mean sensor glucose concentrations, particularly overnight with the use of the CGM. However, the concerns remain about their independent use in the perioperative and inpatient settings due to acute alterations in the physiological and pharmacological conditions and patient capacity. There was a study, we studied this advances in the glucose monitoring and automated insulin delivery published in 2018, and it recommends that with the use of these devices, an early endocrine team involvement should be there, potential removal of the device, and confirmation of all patient reported blood glucose level values with patient hospital point of care testing device. During ambulant and short stay surgery, it may be appropriate to continue the use of advanced insulin pumps. In other circumstances, the device should be removed and insulin infusion used instead. Then we have the inhaled insulins, Afrezza, rapidly acting inhaled insulins. This was approved by FDA in 2014. This was a mealtime insulin. Starts to work immediately after inhalation, peaks in about 12 minutes and wanes off by 3 hours. This is a monomeric formulation, is reputed to be more closely mimic the natural insulin response of the healthy individuals, decreases the risk of hypoglycemia and weight gain. It is contraindicated in asthmatics, active lung cancer or COPDs, and it too should be stopped on the day of surgery as with normal short-acting insulins. Then coming to the another group of drugs, the parenteral drugs, the incretins. Incretins are basically GIT hormones produced in response to the incoming nutrients that contribute to the glucose homeostasis. There are two types of incretins, gastric inhibitory polypeptides and glucagon-like peptide 1. GLP-1 is metabolized rapidly by the enzyme dipeptidyl peptidase 4. This is the main problem with GLP-1. So it has a very short plasma half-life, 1 to 2 minutes, and has to be given by continuous IV infusion. So the solution is to give long-acting GLP agonists which are resistant to DPP-4 inactivation and do not cause hypoglycemia. The adverse effect is nausea and vomiting. The agents are exenatide, liraglutide, and albiglutide. So this report was published in 2017. The effect of continuous exenatide infusion on cardiac function and perioperative glucose control in patients undergoing cardiac surgery. And they concluded that continuous administration of IV exenatide in patients undergoing elective CABG could provide a safe option for intensifying the perioperative glucose management of such patients. Another study, the perioperative management of patients with type 2 diabetes mellitus undergoing non-cardiac surgery during liraglutide, was published in Anesthesia. And they concluded that the preoperative administration of liraglutide stabilized the perioperative plasma glucose levels and reduced perioperative insulin requirements at the expense of increased preoperative nausea rates. So the recommendation is that gastrointestinal effects may be a reason to withhold this therapy preoperatively, but either withholding or continuing GLP-1 therapy preoperative period is clinically reasonable. Coming to the amylin analogs, they are just like incretins. Islet, this is also known as the IAPP, islet amyloid polypeptides, secreted from the beta cells in response to the meals. And they suppress the endogenous glucagon production, reduces postprandial hepatic glucose production, delays gastric emptying, induces satiety, and amylin secretion is diminished in patients with diabetes. Its analog is premelinide. Basically, the three actions: suppresses appetite, slows gastric emptying, and inhibits the glucagon release. The adverse effects are nausea and vomiting, and gastrointestinal effects may be the reason to withhold this therapy preoperatively. Coming to the oral hypoglycemic agents, there are myriad of hypoglycemic agents based on their mode of action. So first is the bicunides. Only one agent is available, the metformin. It suppresses the hepatic gluconeogenesis and glucose output from the liver and enhances the insulin-mediated glucose disposal in the muscle and fat via the GL2-4 and enhance the glucose 1 transporter from intracell site to the plasma membrane. It is a first-line therapy used for type 2 diabetes mellitus. So this is study the association of the metformin use with the risk of lactic acidosis across the range of kidney function. So this is a multi-center study published in JAMA in 2018, and it concludes that in 2 real-world clinical settings, metformin use was associated with acidosis only at eGFR less than 30 ml per minute per 1.73 meters squared. The results support cautious use of metformin in patients with type 2 diabetes and eGFR of at least 30 ml per minute per 1.73 meters squared. Another study published in BMC Pharmacology Toxicology in 1917, metformin is not associated with lactic acidosis in patients with diabetes undergoing coronary artery bypass graft, and it concluded that in the absence of risk factors associated with persistent lactic acidosis such as shock or acute kidney or liver injury, continued perioperative metformin administration was not associated with the occurrence of lactic acidosis in patients undergoing CABG. Elevated lactic acid levels seem to be directly related to tissue anoxia caused by escalating vasopressor support after surgery. Another study published, a randomized control trial published in Anesthesia and Analgesia in 2018, preoperative continuation versus interruption of the oral hypoglycemics in type 2 diabetes patients undergoing ambulatory surgery. And they concluded that metformin does not cause hypoglycemia by virtue of its mechanism of action. And therefore, withholding metformin before surgery may be imprudent in patients without renal dysfunction, particularly in patients with poor baseline glycemic control. However, the American Diabetes Association in their 2019 abridged standards continues to recommend withholding metformin on the day of surgery, especially a major surgery. Coming to another group of drugs, the thiazolidinediones. These are basically the ligands of peroxisome proliferator activated receptor gamma, and they are found predominantly in CNS, macrophages, vascular endothelium, adipose tissues, and pancreatic beta cells. Two agents are available, rosiglitazone and pioglitazone. However, rosiglitazone was withdrawn due to potential risk of myocardial infarction, cardiovascular death, and fluid retention. So we have the study meta-analysis in 2019, the efficacy and safety of pioglitazone monotherapy in type 2 diabetes mellitus. And the meta-analysis supported pioglitazone as an effective treatment option for type 2 diabetes mellitus patients to ameliorate hyperglycemia, adverse lipid metabolism, and blood pressure. Another, the comparative risk of serious hypoglycemia with oral antidiabetic monotherapy was published in 2018, and it concluded that pioglitazone was associated with a lower adjusted hazard for serious hypoglycemia. So in case of elective surgery, thiazolidinediones can be taken on the day of surgery, independently of the time of surgery and fasting duration. Coming to another group of drugs, the sulfonylureas, which are the second line therapy drugs for type 2 diabetes mellitus. Basically, they are insulin secretagogues and stimulate insulin release from the beta cells of the pancreas. Their first generation agents include tolbutamide and chlorpropamide, while the second generation includes glibenclamide, glipizide, and glimepiride. As the effects of the sulfonylurea are independent of the circulating glucose levels, there is an increased risk of hypoglycemic events. A review was published in Diabetes Care in 2017, sulfonylureas and the risks of cardiovascular events and death. And they found that sulfonylureas was associated with an increased risk of cardiovascular events and mortality in minority of studies with no major design related biases. Another study in Diabetes Care, the treatment of type 2 diabetes from guidelines to position statements and back, found in Israel. They have recently updated their diabetes management guidelines and is the first to place sulfonylureas as a third line agent due to the high cost of treatment of side effects despite the low cost of the medication itself. Another study published in Journal of Diabetes Investigation, continuous glucose monitoring reveals hypoglycemia risk in elderly patients with type 2 diabetes mellitus. And this CGM study has demonstrated a higher risk of asymptomatic hypoglycemia with sulfonylureas than other classes of oral antidiabetic agents in non-surgical patients, and presumably in the perioperative settings as well. So the conventional recommendation is to withhold sulfonylureas on the day of surgery remains appropriate. Coming to meglitinide analogs, these are basically the same as sulfonylureas and used as second line therapy of type 2 diabetes mellitus along with metformin. Two agents are available, rapaglinide and neteglinide. This is a study published in 2018, comparative risk of serious hypoglycemia with oral antidiabetic monotherapy, and they found that sulfonylurea was associated with highest rate of serious hypoglycemia. Hypoglycemia appears to be less of risk for meglitinides, but it is relatively high. So in case of minor or major surgery with fasting, patients should omit the dose on the day of the surgery. Coming to another group of drugs, the DPP-4 inhibitors. These basically cause increase in the GIP and glucagon-like protein 1 by inhibiting its degradation by DPP-4. The examples are validagliptin, sitagliptin, sexagliptin, and linagliptin. So this is a study in Lancet that efficacy of sitagliptin for hospital management of general medicine and surgery patients with type 2 diabetes. And they found that treatment with sitagliptin plus basal insulin is as effective and safe and convenient alternative to the labor-intensive basal bolus insulin regime for management of hyperglycemia in type 2 patients admitted to general medicine and surgery services in hospital in non-intensive care settings. So these should not be stopped before surgeries of any kind independently of the fasting duration. Another group of drugs is the sodium glucose co-transporter 2 inhibitors. Basically, SGLT2 is expressed almost exclusively in the proximal tubule of the kidney, and these agents act by inhibition of SGLT2 and thus inhibition of the renal glucose reabsorption, promoting glycosuria and natriuresis in insulin-dependent manner. They are associated with improved glycemic control, reduced plasma volume and blood pressure, renoprotective effects, and promotes the weight loss. However, this is a study, randomized control study in New England Journal in 2005, that empagliflozin, cardiovascular outcomes and mortality. So this basically these agents became after this trial that demonstrated that when they demonstrated reduction in the cardiovascular mortality, myocardial infarction, all cause mortality and hospitalization for heart failure with the use of these inhibitors. However, there is a study published in 2017 that effects of these inhibitors on UTIs and genital infections in type 2 diabetes mellitus, and found that the uroglycemic effect of these is associated with urogenital infections, and these may be of particular concern for patients undergoing gynecological or urological surgeries and who have post-operative urinary catheters. Another study found that ketoacidosis associated with SGL2 inhibitor treatment, and this FAIR data confirms that euglycemic acidosis is a serious hazard associated with these inhibitors. Of particular concern is that 71% of the patients experience euglycemic diabetic ketoacidosis, which may delay the diagnosis. The perioperative period can be a precipitating factor for diabetic ketoacidosis, and risk may be further increased if these therapy is not discontinued or is reintroduced too early in the post-operative period. So recommendations on the appropriate period of cessation prior to surgery range from 24 to 72 hours or longer. Then coming to the agents, alpha glucosidase inhibitors, these prevent the intestinal glucose absorption and primarily reduce the rise in the postprandial glucose. The agents are acarbose, voglibose, and maglitol. Basically, acarbose is a complex oligosaccharide which reversibly inhibits the alpha glucosidases, the final enzymes for digestion of carbohydrates in the brush border of small intestine. Flatulence, abdominal discomfort, loose stools are produced in about 50% of patients due to fermentation of the unabsorbed carbohydrates, and patient acceptability is poor due to uncontrollable GI symptoms. There was a review in 2015, therapeutic potential of alpha glucosidase inhibitors in type 2 diabetes mellitus, and they found that acarbose in particular are more useful in competing postprandial hyperglycemia and glucose variability across the spectrum of diabetic therapy, particularly in the Asian patients. Together with their effect on incretin hormones and gut microbiota, AGS can be considered beyond glycemic control as cardioprotective agents. In the perioperative setting, the recommendation is that if the patient eats in the morning, the drug should be taken. Nevertheless, with fasting, the drug should be withheld and resumed when the nutrition is resumed. So this is basically a sum of all the oral hypoglycemic agents discussed. So to conclude, although the consensus regarding the pertinent perioperative glucose target has been achieved, but strong evidence regarding improved perioperative outcome related to it is still lacking. Optimal antibiotic drug regimes should avoid severe hyperglycemia while preventing hypoglycemia, as the latter is a significant contributor to the length of stay, adverse outcomes, and potential mortality. Recent advances in anti-diabetic drug management in perioperative settings has provided opportunities for improved glycemic control, but the healthcare workers should be familiar with new technology to overcome the associated therapeutic complexity, patient and staff confusion, and medication errors. Thank you.
Thank you, Dr. Jatin. You have covered almost all groups of starting from the traditional one to the newer one. In fact, the topics assigned were quite big, but you have tried to justify your talk. So, like all the three topics are over. So, Dr. Baljit Singh, we can ask for. There is one question by Dr. Kanchi in the chat box. Am I right?
Yeah, that's right. I think it is addressed to Dr. Kirti.
Kirti, yeah.
And he wants to clarify whether SMI is
Yeah.
severe myocardial, silent myocardial infarction or severe mental illness.
So,
Well, Dr.
yeah,
Kirti.
just, yeah.
Thank you, Dr. Kanchi, for the question. Like it is, of course, a silent myocardial infarction when we are talking of cardiovascular complications related to diabetes. Now, the second part of your question is what is your practical approach to a patient with 350 milligram percent, 250 milligram percent, 100 milligram percent, or 50 milligram percent of
Blood sugar level.
blood sugar levels. Sir, what I would like to address, 100 milligrams should not be any problem because it is well within the targets we can accept, that is between 90 to 180 milligram percent. Considering 250, going up, considering 250, of course, in the morning when more than, if morning blood glucose in a controlled patient who's already been prepared for surgery, who's one of our preoperative goal was to optimize the patient in the treatment in the preoperative period. If the blood glucose is more than 180, we start with an IG regime. A 250 milligram percent can be managed with an IG regime and appropriately, like starting glucose and a separate insulin drip and a separate insulin drip and titrating it to counter this blood glucose level, and can be measured, the blood glucose can be measured 1 to 2 hourly, and by the time the operative time comes, maybe we are able to come into the physiological limits, physiological or the accepted limits for the diabetes. Now coming to 350, it becomes a big clinical question. First of all, the question arises whether the patient was adequately controlled or not. Because a patient who's been controlled and there is no aggravating factor, a blood glucose of 350 needs evaluation. Evaluation in the sense we should have at least urine for ketone bodies. We should have serum electrolytes and anything. Why? If we have to review the treatment, if the patient is not controlled properly, it would be because it is around very controversial to take such patient without any investigation for the surgery. Now, and depending upon the type of surgery as well, if it is a cardiac surgery, neurosurgery again, then again, if it is an emergency surgery, of course, we would take it we will manage the blood sugar level in the OR and take up the patient. If it is elective surgery, we would like to investigate the patient, again, bring back the controls, somewhere we have lost some chain, and then would take up for surgery. For the patient who is on 50 milligram percent, an infusion of 10% dextrose, and then reviewing the blood glucose level hourly or 2 hourly. And if we achieve between 90 to 180, then of course we would like to again go in for surgery. I think that should not be a problem, controlling 50 milligram percent as well. And other things should also be evaluated, that the pre-night, the patient, did he or she missed his dinner, or an old age patient, or was the insulin given in the right, or the pre-night drug or insulin was given in the right dose or not. A lot of things need to be evaluated in this patient also.
Thank you so much, Dr. Kirti. I think you have covered the queries which Dr. Kanchi Mulidhar had very well. Just to carry on from there, what about the elective surgery? What about the the emergency surgery? The patient has come to you with, he doesn't have any history of diabetes mellitus, and he comes to you with a blood sugar of 350, and the surgeon says, I have to get this appendix out as early as possible, which they very routinely do. So what are you going to do with that?
So we have to, we will try to control the blood sugar in the OR itself.
Okay, and what kind of regime that you would follow?
So we can go in for an IG regime where we can divide the we can, if we have like an appendix can give us an hour or two. So we can start with an IG regime dividing by the 350 by 100. We can give it 3.5 unit per hour, and then we can go in for sliding scale, whatever being used in this thing. We can go and take it up. And plus, if there are electrolyte abnormalities, in fact, we should add potassium in fact, it is better to add a potassium also to the regimes. But simultaneously, we should look for ketone bodies as well in the urine, to identify if the patient is not in DKA.
And what kind of level would you be happy with in the intraoperative period? Just the range.
So range, we will go for the broader range that the societies have accepted, around about 225 to 225. That is the highest. 226, that is their acceptable. Around about 225 or 250 would be to 225. I would be very happy.
That's the upper limit. What about the lower one?
The lower limit, they go down as low as 76 for like if you take a broader where uncontrolled thing is being subjected to you, an uncontrolled patient is being subjected to you.
Okay. Dr. Shashi, if I can come to you.
Yes.
You had mentioned about the tight control and then the 9 non-tight control and the velour regimen. Yeah. Which is the protocol that you follow in your setup with regard to the management of these patients?
Okay. So in my institute, what I do is like morning blood sugars are there, and intraoperatively for elective surgery, which is not much of fluid and electrolyte shift, till 200 mg%, I don't worry at all. Okay. I like to be, rather than hypoglycemia, I like that patient's blood sugar should be a little high, not through hyperglycemia. And if it is touching 200, then like I give insulin, subcutaneous.
Okay.
And also, if I have syringe pump, then I can make a consultation of 1 unit per ml, and I will titrate according to the sliding scale.
Okay. And how, again, I mean, how much level would you, what kind of range that you would have? Will it be the same as Dr. Kirti has said it?
No, in elective surgery, perioperatively, I would like that the range should be within 140 mg%.
Yeah.
And for critically ill patient who are in emergencies, then 180 mg%, around about, not less than that.
Okay. Now it's not a very uncommon problem.
Yeah.
Patient doesn't have any history of diabetes mellitus, and he says diabetes mellitus. What is that? I mean, he knows nothing about diabetes mellitus. He says neither my father, anyone in the family, right or left, has had it. And he is coming for an elective surgery. The blood sugar is, say, let's say 260. So how are you going to proceed with such a patient?
So the question is for me, Dr. Baljit?
I said that a patient doesn't have any history of diabetes mellitus. In the past, the family history is negative. And when, during routine checkup, he has his blood sugar 260 and he's coming for an elective surgery. So how do you proceed with such a patient in your setup?
So I will first try to find out whether he really has that diabetes, because a single reading of 260, I don't, pay much attention.
Okay.
So I would like preoperatively just to ask history pertaining to diabetic symptoms. Then if yes, okay, fine. If not, I would then go for, blood sugar, random fasting postprandial and glycosylated hemoglobin, and try to find out whether really the patient is diabetic or not. Because, sometimes when the patients are having fractures and they come for semi-emergency, not exactly elective, we often find that blood sugars, they are quite high on the morning. And then, and you find out dextrose drip was being given. So anyway, for a blood sugar level of 260 in an undiagnosed diabetic, so I would try to find out whether he is really diabetic by my investigations, and I would not take the patient for elective surgery.
Okay, so you'll defer it if the surgeon is kind enough. All right. So let's say another situation which is not very uncommon, and I think it's very important from the point of view of postgraduate students. Pregnancy and diabetes mellitus. It's not very uncommon case which is seen in the examination. A patient has come, again, doesn't know about the blood sugar, coming from a rural area, is in the third trimester of pregnancy. Blood sugar is somewhere around, say, 430. So, what are you going to tell the surgeon? She says, look, I want the baby out.
Okay. So, see, I would first like to ask the obstetrician colleague that how urgent, like fetal distress, could you give me 15 minutes? I think this much time, 15-20 minutes, we usually get, maybe half an hour. And then I would like to have one is capillary blood glucose again, point of care, and urine for ketone bodies. If ketosis is present, then of course I will, try to give insulin, and as the time demands, like for whatever time the obstetrician can demand, tell me that it is the time, I will try to control. And if not possible, I will, assess the risk benefit ratio. At the same time, I would also like to ask the obstetrician, how is the fetal condition? Has the fetal ultrasound been done?
Okay.
And if really it's an emergency and they want the baby out, then, risk benefit ratio and regional anesthesia.
Well, yes, I think I tend to agree with you here, because I think it's important to have obstetrician involved in the management of this patient and overall outcome of the patient. So to have her as a partner in the decision, so that makes things smooth eventually. I don't see any more questions. I think the speakers were so good, so sweet. Not because they were discussing diabetes, but because the presentation was very good. I don't see many questions here in the chat box. If any of the attendees, participants, or the faculty colleagues would like to have
comments from
comment or feedback or addition to whatever the speakers have spoken, I would be happy to welcome them.
Dr. Baljit, if can I
please, sir.
Get video on?
Your video, well, your video should be on, but anyway, you can go ahead.
Okay,
Meanwhile,
okay.
Till the video comes out.
Okay, good evening to everyone. I have little, not very many questions, but I have little doubts and suggestions. Dr. Kirti informed us that she'll be happy with 200 or 225 to 226 milligram percent. When patient comes at 350 in emergency, she will give 3.5 units per hour. Yes. But when patient has 350 or so, he will be having lot many electrolyte and fluid disturbances. So he will probably be severely hypovolemic. So all those points have to be kept in mind. And 200 is okay. We'll be happy to have, and then probably infusion will start. But before that, we have to bring to 200 milligram percent. For that, we have to be very, very, very active and very much involved. Give infusion sodium chloride, insulin infusion sodium chloride, fast-acting insulin, of course, to bring down to 200, and then possibly start infusion at 3.5 or 4 units per hour to maintain it somewhere around. We don't want to aim at 250 or 225. No, we don't. We may be happy at times, but we would like to have 140, say 100 to 140. We are not very strictly controlling diabetes because we know the disadvantages of hypoglycemia, but we are also not so liberal that 200 is all-time good. No, it is not all-time good. It may have a lot of deleterious effects on the physiology of the patient. So probably 150, 140 is acceptable. Yes, we can probably at times accept 200, but then we have to do something to bring it down to somewhere around 140, 150. Yes, lower down than 80 probably is not acceptable at any cost. Somebody said 75 or 74, probably that is not too risky. And somewhere around 90 or 100 is probably safer. About one more point, we have to indeed be liberal, but not too liberal in managing diabetes. This is world over accepted. Yes, not very strict, liberal, but not too liberal. Thank you. Thank you so much.
Thank you so much, Dr. Mishra. Well, your words of wisdom and your words of experience mean a lot to everyone. Thank you so much for your kind input.
Dr. Radhakrishnan want to add some.
Yeah, sir, please come in.
I like to ask something, Dr. Shashi.
Please go ahead, sir.
You made a good lecture. But what I want to know is, what is this Vello regime? Could you highlight on that Vello regime?
Vello regime?
Yeah.
Okay. So,
is it practiced now?
see, it is, we are not practicing it. I just brought it so that someone may ask the postgraduates, and if they have not heard it, it's not good. At least they must be knowing that in India, especially.
I am hearing it for the first time, Vello regime.
No,
Sir, it is there. It is there. It is very well accepted, although it may not be used very, very frequently. But there are.
What is the principle behind? That's what I am asking.
The principle is that it is said to provide a better perioperative blood glucose control.
Better perioperative.
Yeah. So it
Now,
has. Okay, I'll just let you know, because it's quite exhaustive,
It is like GIK only. I think they were practicing in some textbooks, not textbooks, some CME notes it is given.
No, it is also given in journals. Even in books also, in journals also, it has been given.
It has its references in I agree with Dr. Shashi that it is, of course, it's a published regimen, and of course it has references in some books also.
Yes.
Although it's little difficult to practice, but I think I'll leave it to Dr. Shashi to give more details on this.
So I'll just give details about it.
To my mind,
if you want to ask that, regular insulin 5 units are dissolved in 500 ml of 5% dextrose, and the infusion is undertaken at a rate of 100 ml per hour.
So 1 unit per hour.
It is started on the morning of surgery until the time of operation.
You give 1 unit per hour.
See, how to give is like, it is to be given, units are to be given according to the blood sugar levels. If it is less than 70, like stop insulin, we all know, 70 to 100, infuse 5% dextrose, 101 to 150, 1 unit of insulin plus 100 ml of 5% dextrose per hour. Likewise, if it is more than 300, 1 unit of insulin for every 50 milligram more than 100 milligram percent plus 100 ml of 5% dextrose.
Yeah. The idea is to provide glucose to the cells.
Yes.
By the way of providing insulin infusion and prevent catabolism. At the same time, avoid hypoglycemia and hyperglycemia. That is the idea.
Oh.
Yeah. It prevents catabolism because you're giving glucose intracellularly by the way of insulin.
Now,
So
what prevents, that's what I am asking for.
Sorry?
What is the base level? At what level you should have this particular regime started?
It depends upon the blood sugar.
Yeah.
As Madam said, depending on the blood sugar, depending on the blood sugar, you have to vary the insulin infusion.
Addition.
And what is the bottom level to avoid catabolism? You should go into this particular regime.
We have to maintain the normal blood sugars. I would go for, as Dr. L.D. Mishra pointed out, my diabetic control intraoperative will have a blood sugar level between 120 to 180 to 180 milligrams. Not 80 or 75. It will be 120 to 180 milligrams, not more than 200 milligrams.
120 to 180, well, we may be able to gladly accept without much problem.
That will be my approach. That will be my approach.
Yeah.
Can I just add?
Yes.
That if the patient is stable, then I think less than 140. And if it is emergency surgery or critical, a little bit higher, say less than 180.
Then 180.
Right.
And I would like to add 2 comments. One is
in the prevention of AKI in diabetic patients, maintenance of mean arterial pressure is also important.
Very important.
That should be included in the risk factors. Hypotension of a long duration is going to cause AKI. Second thing is, in our own experience in diabetic patients undergoing coronary artery bypass grafting, if the diabetes is well controlled, the hospital mortality and the immediate outcomes are similar in both diabetic and non-diabetic patients.
Yes.
That is our, we have done our own series, and that is our inference.
Well, thank you so much, Dr. Kanchi, for adding your, from your experience. Yes, Dr. Radhakrishnan.
Not much discussed regarding the subarachnoid or the epidural blockade in a diabetic patient.
Yes.
Yeah. And purposely avoid, I think, because if it is autonomous compromise,
yes,
will you go ahead
No.
with spinal blockade or with an epidural blockade?
See, if the patient has autonomic neuropathy, so first I would like to say that like to assess what is the degree of autonomic neuropathy, and if regional anesthesia is deemed necessary, I would go for it, like again for lower limb surgery and that fracture management and like that. And I will manage the blood sugar. I will take care that hypotension should not occur.
I am asking, not asking for the blood sugar level. I am telling patient is having autonomic neuropathy. Patient is exhibiting symptoms of autonomic neuropathy. Will one go ahead or one justify in going ahead with a subarachnoid block or with an epidural blockade?
I would like to have, combined spinal epidural with a low dose spinal and followed by epidural. Otherwise, sole epidural can also be used.
So basically, the point is that these patients are going to have blood pressure drop very, very rapidly as compared to the normal patients. And of course, epidural is better. And we cannot say for sure for every patient whether we go for combined spinal epidural or epidural alone or subarachnoid block. It depends on the surgery and what is the preference of that particular surgeon. But I fully agree with Dr. Shashi that combined spinal epidural is a good option. You can have longer duration of anesthesia and of course postoperative analgesia also in these patients, and of course subarachnoid block for a quick block.
And along with local anesthetic, I would like to add adjuvants like fentanyl so that hypotension should not occur.
Very true. Yeah,
and
very true.
At all it occurs, I will manage it.
Yes, quite right. Quite right.
One last comment I would like to make, if you don't mind, Baljit.
Sir, please, although
see, I asked about 350 milligrams % fasting blood glucose on the day of surgery. It really happened in my setting.
Sir.
About 4 years ago.
Yeah.
One patient had 350 milligrams at 6 o'clock in the morning, and they contacted the diabetologist. The diabetologist said give 8 units of subcutaneous insulin, and this nursing staff gave that immediate straight away. But when the patient reached the theater by 8 o'clock, the patient was disorientated and the blood sugar was 50.
Oh.
So that's why we have to be very careful when we give insulin, when we are not giving any food to the patient. So probably they should have adapted the Vellore regimen, or they should have given glucose insulin infusion so that the blood sugar is controlled. At the same time, patient does not become hypoglycemic. That's why I just asked that question. And about the silent myocardial infarction, the entity called serious mental illness carries a very grave progress in diabetic patients. And that's why I asked whether, I was not sure whether she was meaning severe mental illness or silent myocardial infarction in that list of things in the preoperative evaluation. So I just wanted to clarify that point. Thank you. Thank you very much for having me.
Thank you. Thank you so much, Dr. Kanchi, for adding your inputs, very valuable, important inputs. I think we are already exceeding the time.
Yeah.
I would, Dr. Kishan, would you like to set up, or first of all, I would like to all the speakers for the excellent presentations. There were good feedback from the participants that they enjoyed these presentations, and one was asking with regard to whether lectures would be available on YouTube. Always there. Every the webinar are available on YouTube. So fill up the and you get certificate.
Baljit, your voice is breaking.
Doctor.
It is net is breaking, madam, not voice. This is technology.
I think, Baljit, your voice is breaking. I think, Baljit? Dr. Radhakrishnan, can you conclude, please?
I thought you will be doing it.
Sorry?
I thought you will be doing it.
Yeah, so I'll do it, no problem. I couldn't hear actually properly. Thank you very much for that excellent webinar. I'm so thankful to Team Rohtak for having accepted this. Of course, they are a part of us, North India. And thank you so much. We had such eminent speakers, Dr. Kirti, Shashi, and Jatin. And all the topics were so well covered. I mean, diabetes has been completely covered right from pre-op to the recent advances. Thank you so much. And I'd like to thank Dr. Singhal, who was so kind enough to moderate this session, and Dr. Baljit Singh, of course, our CEO, who's so active in the ICA. So thank you very much, all of you, and see you next week, same time on Onco Anesthesia. Thanks a lot. Good night, everybody. Good night. Thanks a lot.
Bye.
Bye-bye. Good night.
Thank you.